Okay, so we're going to look at the second part of chapter 22. More details dealing with the mechanisms of how everything works and various values, like your your total lung capacity, your TLC, your VR, your FVC, which you'll see in when we get into this chapter, but it's a little more detail. It's not just the anatomy. So there's more than just the anatomy of the respiratory system, but how does everything work? Why does it work? Where's the information coming from? So that's what this part is going to look at. So breathing is under neural control. Now the skeletal muscles of breathing cannot contract without nerve stimulation, and breathing involves central coordinating mechanisms. Now, breathing is controlled at two levels of the brain, one being the cerebral and the conscious, and the other being the autonomic and unconscious. The autonomic unconscious cycle of the breathing is controlled by three parts of the respiratory system center, in the reticular formation of the medulla oblongata and the pons. Okay, so before we move on to that, I just want to mention that when we deal with inspiratory neurons, they're the ones that's going to fire during inspiration. So when we're about to inhale, take a deep breath in, we're dealing with inspiratory neurons. When we exhale, we're dealing with expiratory neurons. Now we do have innervation, and those are the fibers of the phrenic nerve which supply the diaphragm, and then we have those nerves, the intercostal nerves, that are going to supply the intercostal muscles. So let's move on. Let's move back now to what I was referring to. The three parts of the respiratory centers that help with controlling the unconscious cycle of breathing, and they're located in the reticular formation of the medulla, as well as the pons. Okay, so let's look at the first one, which is our VRG. Now I'm going to move the slide. This is where all the information is concerning the various information I'm going to go over, the three types, but I just want to stick on the diagram so you can actually see what I'm talking about. So let's look at the very first one, our VRG. Our VRG, here it is right here, which stands for ventral respiratory group. Now it is the primary generator of the respiratory rhythm. Okay, and it's located here. It is an elongated nucleus in the medulla. Sorry, so this is medulla, this is the pons. This is the pons, I'm sorry, I mixed it up. This is the pons, and here's our medulla. So, it's elongated nucleus, as you see here, elongated, looks like a capsule, in the medulla with two commingled webs of neurons. We have an inspiratory neurons, and we have our expiratory neurons, which I just talked about just a few minutes ago. Now, each forming a reverberating nuclear circuit. Now, in quiet breathing, which is apnea, the I, or the inspiratory neurons, they fire about 2 seconds at a time. Okay. Output travels by way of the phrenic and the intercostal nerves. Where is it? Okay. Here we have it firing out into the intercostal and our phrenic nerves. Okay. Now, as long as the I, or the inspiratory neurons are firing, they're going to inhibit the expiratory neurons. So as long as these neurons are firing and saying, yes, we're going to inhale, the neurons that want the, or that are used to used for expiration are not going to fire. And it's just because the neurons, come on, the inspiratory neurons are firing at that particular time. So once they're firing, these expiratory neurons are not going to fire. Now eventually the inspiratory neuron activity it wanes, and the expiratory neurons begin to fire, which further inhibits the inspiratory neurons and allows the inspiratory muscles to relax. So eventually these neurons are going to stop firing. The expiratory neurons are actually going to fire and allowing you to exhale whatever it needs to be exhaled. And these inspiratory muscles are actually going to relax during that particular time, during that expiration. Now the expiratory neuron activity begins to wane after 2 seconds. When we talk about wane, starts to decrease. Now the expiratory rhythm produced is about 12 beats per minute. This our respiratory rhythm produced is about 12 beats per minute. Okay, so let's get on to our DRG, our dorsal respiratory group. So here is our dorsal respiratory group. It's another web of neurons that extends for much of the length of the medulla between the VRG and the central canal of the brainstem. The DRG is apparently an integrating center that's going to receive input from several sources. So you see it's receiving several sources here. Receive information from several sources. So these are like junctions, if you remember from the nervous system. But we have various junctions here that are going to end up in this DRG. Now, this include the inspiratory center in the pons, a chemosensitive center in the anterior medulla oblongata, the chemoreceptors in major arteries, and the stretch and irritant receptors in the airway. Now the DRG issues output to the VRG. So you have the DRG, it's going to give input to our VRG. And this is what's going to modify the respiratory rhythm to adapt to various conditions. So if you are running a race, yes, you're going to get these signals from the DRG to the VRG for you to either inhale or exhale faster, for these muscles to relax and contract according to whatever exercise you're doing. If you're sitting on still, then the information, hey, the person's just sitting down, relaxing. We don't need to work as hard. Inhale and exhale normally. Do that the 12 beats per minute respiration cycle. Okay, that's how that works. Okay, then we have our PRG. This is our pontine. I might pronounce it wrong. Pontine respiratory group. Also, it's formerly called the pneumotaxic center, and this is what modifies our VRG. It modifies the rhythm of the VRG. Okay, so this PRG located here in the pons, it receives information from higher brain centers, including the hypothalamus, the limbic system, and the cerebral cortex. Now it issues output to both the DRG and the VRG. So you see the various inputs from the PRG. It receives it from the medulla, the hypothalamus, the limbic system, and of course the cerebral cortex. And then they relay the information. This PRG is going to relay this information to the DRG as well as the VRG. Okay. Now, it hastens or delays the transition from inspiration to expiration, and is going to adapting breathing to special circumstances such as sleep, exercise, vocalization, and emotional response. So that is our PRG, our DRG, and our VRG. Now you see exactly where they are located. Okay, and here's the information, like I told you, that you will find concerning these particular centers. Alright, so let's look at hyperventilation. What's hyperventilation? Now, when we have extreme anxiety is one example that can produce hyperventilation, that can lead to dizziness or fainting as CO2 is expelled too quickly, causing a rise in our pH. So that's someone having a panic attack, and they're inhaling or they're exhaling so much that not enough O2 is getting into the body. You're expelling so much CO2 that there's not enough gas. There's insufficient or imbalance of CO2 and O2 exchange within your alveoli, and with that is going to cause your pH to increase, and it's going to cause cerebral arteries to contract. Okay. Now, multiple sensory receptors also provide information to the respiratory centers. The central chemoreceptors in the brainstem that respond to the change in the pH of the cerebrospinal fluid. So when the brain notices that there's an imbalance, the homeostasis is off, is not there, these signals are sent to the central chemoreceptors within the brain. Within the brain stem, sorry. Now the peripheral, let's see if I can catch up with my notes, because I'm just going ahead. I get excited when I talk about the brain, when I talk about the heart and the lungs. Okay, so let me try and stick with the slide, because I'm going ahead of myself a little bit. So when you have that increase of pH due to the person hyperventilating, it can cause a person to get dizzy or faint, and that's because you have a decrease of cerebral perfusion. With that, you're gonna have tachycardia, which is an increase of your heart rate. You have dyspnea, and that can lead to numbness or tingling in your hands or feet. Can cause anxiety or either sore chest muscles. So that's a person breathing in and out, panicking, like having a panic attack. Okay, and that can be brought under control by having the person rebreathe the expired CO2 from the paper bag. And this causes anxiety, causes of hyperventilation. We have anxiety, we have fear. Some medications can do it, definitely can. Allergic reactions and have medication. We have intense exercise and emotional stress. Alright, so let's get back to these centers I was talking about. Now we have these control centers. You have these receptors. We have a central chemoreceptors, and we have and we have peripheral chemoreceptors. When we look at the central chemoreceptors, they're the ones that are found in the brainstem, and they're going to respond to any type of changes that we have in the pH of the cerebral spinal fluid. The pH of the cerebral spinal fluid, or the CSF, they're going to reflect the CO2 level in the blood, and by regulating this respiration to maintain the stable pH, the respiratory centers also ensures that the CO2 is stable in the blood. Now the peripheral chemoreceptors they're located in the carotid and the aortic bodies of the large arteries, which you see here, the carotid arteries, and we have the aorta. So we have the aortic bodies of the large arteries, and they're ones that are going to respond to the CO2 and the O2 and the pH of the blood. Let me see if I have anything else underneath there. There we go. and they're going to convey or relay that information via the cranial nerves to the neurons of that DRG. Remember we talked about the DRG? Good. Now we have these stretch receptors. Oh, here we go. Here are these aortic bodies that I was referring to, the aortic bodies that are on the aortic arch. And we have the carotid carotid bodies that you see here that are going to relay that information. Okay. Alright, so let's get to our stretch receptors. The stretch receptors in the smooth muscle of the bronchi and the bronchioles, as well as the visceral pleurae, they respond to inflation of the lungs. Excessive inflation triggers the inflation reflex, which is the Heron-Breyer, that inhibits the inspiration neurons and stops inspiration. So when you try to inhale too much, basically you're taking a deep breath, basically these receptors, these stretch receptors say, hey, you know what? They're responding. She's inhaling too much. It's time to exhale. We've stretched as far as we can stretch. It's time to exhale. And that's where the inflation reflex kicks in and allows you to exhale. It stops the inspiration and allows you to exhale. Then we have the irritant receptors. They're nerve endings amid the epithelial cells of the airway, and they respond to smoke, dust, pollen, chemical fumes, cold air, and excessive mucus. And they're going to transmit signals to the DRG, that in turn initiates the protective reflexes as bronchoconstriction. How do you remember what bronchoconstriction is? Where the bronchos contract, or they get smaller, or they start to close up a little bit. Shallow breathing, deep holding, or that's breath holding, which is apnea, or coughing. Now, voluntary control of breathing is important in singing, speaking, breath holding, and other circumstances. Now, this control, it originates in the motor cortex of the frontal lobe of the cerebrum. Now, output neurons, they're going to send impulses down the the corticospinal tracts to the integrating centers in the spinal cord, bypassing the brainstem centers. The voluntary control has limits. What are those? I'm holding one's breath, for example. That's going to raise the CO2 level of the blood until a breaking point is reached, and automatically control overrides one's will. Now, divers, they have a different type of breaking point, and that just comes with training. Okay. Now, the laws of physics. Hopefully I'm on the right page. Yes, I am. All right, laws of physics. It governs pressure, resistance, and airflow, as well as transport of gas in the blood and their exchange with tissues. Now, the respiratory airflow is governed by the principles of flow, pressure, and resistance as blood flow. And let me see if it's there. Okay. So you might see you might see this in your textbook. I'm trying to. Okay. Can try and draw this out. Alright, so what does this mean? This means that the flow of fluid. Let me get out of this. Okay, so this means that the flow of fluid is directly proportional to the pressure difference. This means that that's difference, pressure difference. So that's P1, P2 minus P1 divided by our resistance. Okay, so with that, if the 2 points, if it's directly proportional, that means that the flow, if flow increases, pressure is going to increase. Now, if the flow is inversely proportional to the resistance, should I highlight that? If the resistance increases, then you're gonna have the opposite reaction when it comes to flow. It's going to decrease. Now, the pressure that drives respiration is called atmospheric or barometric pressure. Now, at sea level, this pressure is 760 millimeters of mercury, or 1 atmosphere, which is defined as 1 atmosphere, and is lower at higher elevations. Okay, good. Now, pressure can be changed by changing the volume of the container. Now, Boyle's law states that a constant temperature, pressure is, he states that at constant temperature, pressure is inversely proportional to the volume. So if I have a temperature of just say of 30, my pressure is inversely proportional to the volume. So the pressure that I'm going to get, if the volume increases, then the pressure is going to increase. If the lung contains a quantity of gas and the lung volume increase, then the internal pressure is going to decrease. So think of a container. It's a large container. The inside, the pressure is long as well as often as, let me see if I can draw it for you. As often as the temperature stays the same. Here's one container here. We have pressure inside, our internal pressure. Just say the container is about 20 milliliters. And this is 20 millimeters. Just making up numbers right here. Then the inside, just say that the inside pressure, the internal pressure, we'll just say it is, let's say it's 15. Okay. So as the temperature is still the same, of 30 degrees. Temperature over here is still 30 degrees for our second capsule, second bottle. So here we have a larger container. We can say it is now 30 milliliters, and our pressure is going to decrease. So now we're at 10 internal pressure. Then we have a larger container holding approximately 50 milliliters of air. Temperature is the same at 30. Our pressure, our internal pressure, may be down to about, just say, 2. So as the volume increases at a constant pressure, the internal pressure is going to decrease. Does that make sense? I hope it does. Let's see if I can erase this now. Excuse me for 1 second while I get rid of all this stuff. Come on. Okay. So that explains that with Boyle's law. So if volume increases, internal pressure is going to do what? It's going to drop. Now, if the intrapulmonary pressure drops lower than this atmospheric pressure, and the atmospheric pressure really said was 1 atmosphere or 760 millimeters of mercury. If it drops below that, then the air flows down its pressure gradient into the lungs. Now, if the intrapulmonary pressure rises above this atmospheric pressure, air flows out of the lungs. Now that was that video I had in part 1. I think I might have to move it into part 2. But that's an example of what we are referring to with the intrapulmonary pressure. Now, in discussions of the respiratory cycle, the difference between atmospheric pressure and intrapulmonary pressure is relatively is used. Let's see. I'm gonna go back one slide here. Okay, so when we talk about the difference between atmospheric pressure and intrapulmonary pressure, a relative pressure of -3. Right again. When we have -3 millimeters, that's an M, of mercury, it means, let's fix that, it means that we have 3 millimeters of mercury below the atmospheric pressure. That's an M, sorry. But when we have a positive 3 millimeters of mercury, it means that we have 3 millimeters of mercury above our atmospheric pressure. That's ATM, I'm sorry. Okay? Alright, so when we look at inspiration is the flow of air into the lungs. So here we are at rest. Diaphragm is in its normal position. We have the pleural cavity. We have the intrapulmonary pressure at 760. We have the atmospheric pressure, which is outside, is 760. Inside is an intra, meaning between or within, pulmonary pressure within the lungs, that's 760. And our intrapleural pressure is -4. Okay, this is at rest. Everything is equal. Atmospheric pressure and intrapulmonary pressure is equal. Now, when we inhale, these values are going to change. So we're bringing in the pressure. Now, at the beginning, there is no movement of the thoracic cavity. So here we are in step 1. There's no difference between air pressure inside and outside, and there's no airflow. Now, as the thoracic cavity expands, so here we are in step 2, the 2 layers of pleural stick together like wet paper, and this stretches the alveoli within the lung. The entire lung expands. As the lung expands, its internal pressure drops and air flows in. Now, between the 2 layers of the pleural, the intrapleural pressure is a slight vacuum of -4, and it drops to -6 during respiration. Now, within the alveoli, the intrapulmonary pressure, it drops to about -3 millimeters per mercury. Now, another force that expands the lungs is the warming of the air. According to Charles' law, the volume of gas is directly proportional to its absolute pressure. On a day when outside air is extremely cold, 60 degrees Fahrenheit, the air temperature will increase by 39 degrees Fahrenheit during inspiration as it warms to 99 degrees Fahrenheit. by the time it reaches the alveoli. So the air pressure at first, on a certain day, it'll be 60 degrees. The air temperature will increase by 39 during inspiration, and then by the time it gets to the alveoli, it is 99 degrees Fahrenheit. Okay? Now, inspiration starts when the intrapulmonary pressure is equal to the atmospheric pressure. In quiet breathing, the total volume increases by 500 milliliters. Now, expiration is the flow of air out of the lungs. Now, expiration is a passive process achieved mainly by elastic recoil. Now, this elastic recoil compresses the lungs, raising the intrapulmonary pressure to about positive 3 millimeters of mercury. Air flows down its pressure gradient out of the lungs. In forced breathing, the accessory muscles, they're going to raise this intercellular pressure to as high as positive 30 millimeters of mercury. Now, the effect of the, let's see if I can get to that place. Charles' law. Dimensions, forced breathing. Okay, here we go. Now, the effect of pulmonary elasticity is evident in the pathological state of pneumothorax. Now, pneumothorax is the presence of air in the pleural cavity, such as due to a puncture of the thoracic wall, turning the potential space of the pleural cavity into an air-filled space. Now, without negative intrapleural pressure, the lungs recoil and collapse. That is considered to be, I cannot get this pronunciation, atelectasis. Okay, so with pneumothorax, is dealing with the presence of air within this pleural cavity. Okay, it occurs when air leaks between the chest wall and the lungs. Now, this air pushes on the outside of the lung and makes it collapse. So see it collapsing right now. What causes it? You have a blunt or penetrating chest injury, certain medical procedures involving your lungs or damage from underlying lung disease, CPR, airbag deployment, fractured ribs, or lung biopsies. Now, some symptoms you'll have because of this, you have mild to severe dyspnea, shortness of breath, sudden and short angina. Now we have, that's chest pain, angina's chest pain, just need shortness of breath. Now the thoracic wall is punctured, and we have inspiration is sucked in order to help alleviate or reduce this, or get rid of the pneumothorax, get rid of the air in that pleural cavity. They will make a puncture, they'll puncture the thoracic wall, and they'll suction out the air within that particular pleural cavity. And hopefully the potential space becomes an air-filled cavity. Loss of negative intrapleural pressure allows the lungs to recoil and to collapse. Then we have this one here that I was trying to pronounce, atelectasis. This is the collapsing of the lung. So this pneumothorax causes the lungs to collapse, which is electasis. Okay, so you see right here the collapsed lung, and it develops when the tiny air sacs alveoli within the lung become deflated. Okay, it can also result from air obstruction as blood absorbs from alveoli distal to the obstruction. It can be serious because it impairs the exchange of CO2 and O2 in the lungs. What are some causes? Common causes? We have mucus in the airways after surgery, cystic fibrosis, inhaled foreign objects, severe asthma, and chest injuries. What type of symptoms will the person have? Low-grade fever in children, coughing, rapid, shallow breathing, and dyspnea, which is shortness of breath. Now when we look at resistance, resistance is another determinant of airflow. So if you have something preventing you from breathing in, it will definitely hinder the amount of air that's going to enter into the lungs for gas exchange. Okay. The greater the resistance, the slower the airflow. Now resistance in the lungs is governed by three factors: the diameter of the bronchioles, pulmonary compliance, and surface tension of the alveoli and distal bronchioles. So let's look at the diameter of the bronchioles. We're dealing with the ability of the bronchioles to change their diameter, and it makes them the primary means of controlling the resistance. So as an increase in the diameter of the bronchus or bronchiole is called brachial dilation. So when the diameter increases, when the bronchioles get larger, start to enlarge, the diameter enlarges, it's called bronchodilation. When that space decreases, gets smaller, it's called bronchoconstriction. Now we do have some things that stimulate the bronchodilation, and that is the epinephrine and sympathetic stimulation. And it helps with the increase of airflow. So if someone has asthma, a type of COPD, they'll take some type of sympathetic stimulant so that they can breathe. So they need a bronchodilator. There's something just to open up the passageway because they cannot. They're actually closed or closing, and that's why they're coughing and cannot breathe properly. And with their bronchoconstriction, because now the airflow is dilated too much, you need to decrease slightly. You have histamines and parasympathetic nerves, cold air, chemical reactants that will stimulate the bronchoconstriction. If it's too cold outside, it's going to constrict. Certain chemical irritants, your bronchos are going to constrict because they don't want it inside. They don't want to exchange these harmful irritants. So what happens? You have suffocation from extreme bronchoconstriction brought about by asthma or anaphylactic shock. So our second factor that influences air resistance is our pulmonary compliance. This term refers to the ease with which the lungs expand, or the change in lung volume relative to a given pressure change. Now, the thoracic cavity cage, may produce the small intrapleural pressure in two different people, but lungs will expand less in one with poor pulmonary compliance. So if your lungs aren't good, your lungs are not going to expand as much as someone that has a healthy set of lungs. But the compliance can be reduced by degenerative lung disease, such as TB, tuberculosis, and black lung disease. Surface tension, number 3. Surface tension of the alveoli and distal bronchioles. Now, there's a thin film of water that's over the epithelium of the alveoli, and is necessary for gas exchange, but may be a problem for pulmonary ventilation if hydrogen bonding causes alveoli collapse. Okay. The greater alveoli cells, they produce a surfactant, which disrupts hydrogen bonding and reduces surface tension. This surfactant is composed of amphiphilic am- amphi amphilic proteins, and phospholipids, which are primarily hydrophobic. Now the molecules, they spread over the surface of this water film like floating ice cubes. The surfactants, they resist compression as the alveolus deflates, retarding and then halting its collapse. Now we have here. We have infant respiratory disease syndrome, or IRDS. In premature infants, is often treated by administering artificial surfactants. Alright, so here's a little more on the IRDS. It's also called the neonatal RDS. And this substance helps the lungs fill with air and keeps the air sacs from deflating. Surfactant is present when the lungs are fully developed. Now, most cases of RDS occurs in babies born before 37 weeks. They have great difficulty in breathing, and they're treated with artificial surfactants until lungs can produce their own. Other factors that increase the risk of RDS, they include a brother or sister who has RDS, diabetes in the mother, cesarean delivery or injection or inducing of labor before the full term, problems with delivery that reduce blood flow to the baby, multiple pregnancies, twins or more, and a rapid labor. Now symptoms, of course, you have grunting, nasal flaring, decreased urinary output, brief stop in breathing, shallow breathing, shortness of breath, and grunting sounds while breathing, and as well as rapid breathing. There's some symptoms, okay? I kind of added that stuff in. I thought it was very important. Alright. When we look at the alveolar ventilation, we're going to look at gas exchange in the alveoli or the alveolar ventilation. And it can be affected by different factors. Okay. Not all air that is inhaled gets as far as the alveoli. About 150 milliliters of it fills the conducting division of the airway, which is termed the anatomic dead space, since no gas exchange can occur there. In pulmonary disease, some alveoli may be unable to exchange gases because of reduced blood flow or thickened alveolar membrane. Physiological or dead or total dead space is the sum of anatomical dead space and any pathological alveolar dead space. Let's see what's on this page. Okay, so let's go back to this anatomical dead space. What are some things that may alter this anatomical dead space? We have sympathetic and parasympathetic stimulation, which is dealing with the contraction or relaxation of airway smooth muscles. Then we have a change in tidal volume. When we have an increase in tidal volume, you have an increase of traction in our anatomical dead space. So we have pulmonary diseases. In pulmonary disease, some alveoli may be unable to exchange gases because they lack blood flow, or the respiratory membrane has been thickened by edema or fibrosis. Now, the physiological total dead space, as I mentioned, is the sum of the anatomical dead space plus any pathological alveolar dead space. So here is our physiological dead space. Here's our anatomical dead space, and here's our alveolar dead space. So when we deal with the anatomical, we're dealing with the that area with the bronchioles, the bronchioles, and the resistant respiratory bronchioles. And in terms of the alveolar space, we're dealing with the space within the alveolus. Okay. Now, a person inhales approximately 500 milliliters of air, and 150 stay in this anatomical dead space. So that leaves 350 that will reach the alveoli. So the alveolar dead space is the sum of the volumes of those alveoli which have little or no blood flowing through their adjacent capillaries. Alveoli that has vented but not perfused, and where as a result no gas exchange can occur. Now our AVR, alveolar ventilation rate. This is the amount of air that ventilates the alveoli times the respiratory rate. So we already said that we have 350 milliliters of air entering into the alveoli, correct? Then we're going to multiply it by a respiratory rate or respiratory cycle, which is 12 beats per minute. This gives us a total of, this is normal now, this is not diseased or exercise, these are normal values. It gives us a value, our AVR value of 4,200 milliliters per minute. Of all these measures, this one is most directly relevant to the body's ability to get oxygen to the tissues and then dispose of the carbon dioxide. So we're looking at healthy values. Now our residual volume. So now we're looking at different values that you have during respiration and expiration. We have our residual volume. The normal value is 1,300 milliliters, and that cannot be expelled with maximum effort. This is the volume that stays in the lungs. No matter if you exhale as hard as you can, you're always going to have that small bit of volume left inside. Let me go back. Something's wrong. Okay, so I have this video set up just to show about CO2 exchange, the movement of CO2 and carbon dioxide. Let's see if it works. Okay. Move on to the next slide. Alright, so we have a test that is done or performed, to determine what type of lung disease you may have, or if you have any type of lung disease. So they're called PFTs, pulmonary function tests. Now they're there to determine the cause of any breathing problems. So if you have any difficulties breathing on a consistent basis, they will usually, if you don't have any history of it, the first determinant, if you don't have any history, they'll put you through a set of tests, a pulmonary function test, to determine what is the problem, is there even any problem. Now if you have history of it and they know it and you're still having complications, they'll put you through PFTs again to see if the medication that they have you on is actually working. So they're here to diagnose certain lung diseases such as asthma and chronic COPD. They evaluate a person's lung function before surgery, and monitor the lung function of a person who is regularly exposed to substances such as asbestos that can damage the lungs. Now this one here we talk about before surgery. I wonder why they want to do that. That's just to make sure that if the person is under general anesthesia, that they're not going to die. If your lung capacity is not up to par, or you have very low values, they will not perform a surgery on you because they don't want you dying on the table. And lastly, to monitor the effectiveness of treatment for any type of lung disease, to make sure that the medication that they prescribe for you is working. So here we have a pulmonary function test. You have the exercise physiologist or the pulmonary technician. Some of them, they'll have you in a chamber and they perform the test. Some of them, they'll have you sitting right next to them, and they'll verbally demonstrate or verbally instruct you of the breathing techniques that you're supposed to perform. And they'll look at the monitor at various values, different readings, and you have, this is what we'll actually look at, a screen that has a graph and the various values will show up for us, for the technician, of what they're supposed to, of what is occurring while the person's breathing. They're not supposed to smoke or drink prior to the test, because it will actually cause inappropriate or wrong values. So this, what the measure is called a spirometry. The test is called a pulmonary function test, but they use spirometry to measure the pulmonary function. And there's a spirometer, which is what you see here, to help with measuring as well. So it aids in the diagnosis and assessment of restrictive and obstructive lung disorders. Both share the same main symptoms, such as dyspnea, shortness of breath. So someone comes into the office and, hey, I can't breathe, I have shortness of breath. Most likely, if the doctor's office has this equipment there, they'll send them back to the technician, and they will perform these PFTs and determine what type of disorder they'll have, either restrictive or obstructive type of disease. Okay. Now, when we look at the spirometer, so I said, this is a device that recaptures expired breath and records such variables as rate and depth of the breathing. So you have one test, you'll have them breathe as fast as they can, in and out, deep breaths, and also the speed of the respiration. If you can't breathe in and out as fast as to obtain normal volumes, you have some type of disorder, either restrictive or obstructive. And then the rate of the oxygen consumption. Can you breathe in? Can you inhale as deep as a normal person can? Are you taking deep, short inhalations and you're expanding, blowing out a lot of air? Are you inhaling a lot and blowing out a little bit? So those are those little things that they'll actually look at, and they'll actually records, and they'll give us these particular values. You have a respiratory value. This is our tidal value, our TV, which you'll see again. This is the volume of air inhaled and exhaled in one cycle during quiet breathing. So right now you're sitting down quietly. Breathe in normally, breathe out. That's considered your tidal volume. That normal value is 50 is 500 milliliters. That's normal. Now your inspired reserve volume, this is your IRV. So you'll see these abbreviations a little bit later. This is air in excess of tidal volume that can be inhaled with maximum effort. So that's the doctor telling you to take a deep breath in. If you take a deep breath in and you're at 3,000 milliliters, you can basically, you're somewhat normal. Now your the value is normal, sorry. Now your expiratory reserve volume is based on the amount of air that you're going to exhale with maximum effort. So when you inhale deeply, as much as you can, and then all of a sudden you exhale and you force everything out, that's considered your ERV, your expiratory reserve volume, and that volume is 1,200 milliliters. So here is a chart. We have here we have our tidal volume. This is normal breathing. Breathe in, the line goes up. You breathe out, you exhale. Inhalation, exhalation. It'll go all the way through. Depending on exercise, they will tell you to blow everything out, and you'll have to exhale everything out, and it reaches here. This is 1,200 milliliters of of our ERV. That's what it's called, our expiratory. Our expiratory reserve volume. Then we go back up here. This is our tidal volume, which ranges at our normal value of 500. Then you take a large breath. You inhale as much as you can, and it should reach approximately, what did I say it was? 3,000 milliliters. Okay. So don't forget, I know you're looking at 3,000. Why is it 3,000 here and we're all the way up here? Well, we're starting off here at these values, between the value from here to here. This shaded in area is 500 milliliters. Yes, we're here starting at 3,000, but the distance from 3,000 to here is 500 milliliters. The distance from 3,000 to 6 is 3,000 milliliters. So yes, we are looking at these values, but we're also looking at the shaded area, and the difference between the 600 and the 300 is our 1,000 is our 3,000 milliliters. Okay, which gives us our inspired reserve volume. Here we have our tidal volume again at 500 milliliters, our inspiratory and our expiratory. So this is someone telling you to take a huge deep breath in, then exhale as much as you can. That's considered to be your tidal, your VC, your vital capacity. It is your inspired, your IRV plus your ERV gives you your tidal, your vital capacity. Now we have our your inspired capacity. Your inspired capacity is basically the amount is your tidal volume, which is you breathing normally, your apnea, plus your inspired volume. So they're going to calculate your breathing volume, your normal breathing volume, TB, as well as the amount that you inspired. That will give us our inspired capacity. Then we have our functional residual volume. Well, let's go back here. Now, our residual volume. The residual volume is basically what's left back in your lungs after you have blown everything out. So as you blow everything out, you'll have something left back in your lungs, and that's what that residual volume is. So our functional residual volume is the amount that you expired with the maximum effort plus the amount that is left back in your lungs after you've expired to your maximum. So that's your FRC. Then your total lung capacity is your IRV, your IRV plus your TV plus your your ERV plus your RV. So it's everything, the blue, the purple, the yellow or the orange, plus the dark blue and the light blue. That is your total lung capacity. How much can your lungs hold? How much can you expel out, and what is left back after you expel? Okay. So here are our values again. Our residual volume, which we went over, the air remaining, that's your RV, remaining in your lungs after you've expelled everything out, 1,300 milliliters. Our vital capacity is the total amount of air that can be inhaled and then exhaled with maximum effort. So as you've taken a deep breath in and exhaling everything out, and they're going to calculate what you have. That normal value is 4,700 milliliters. Told you you'll see those abbreviations again. This is important to measure our pulmonary health, because you know they're gonna definitely will ask you to perform this type of test, just to see are you gonna meet there. If you're low, you have some type of disorder. Then you have your inspiratory capacity, which is the maximum amount of air that can be inhaled after a normal tidal volume. So you breathe normally, then until you inhale as deep as you can on my signal, and you inhale as much as you can. And it should, if normal, be 3,500 milliliters. Then we have our functional residual capacity, our FRC. That is the amount of air remaining in your lungs after a normal tidal volume. So they're going to tidal expiration. So you exhale, and they're going to measure how much you have left back, as well as the normal, which should be 2,500 milliliters. Then we have our total lung capacity, which is our RV plus our RC. You might wonder, RC, that's not what she said. I'm going to go back to the chart. RC plus VC. Our RV, I'm sorry, it's RV. It's our RV plus our VC. Here's our RV, our residual volume. This is this light blue area. So it's our RV plus RVC. The light blue air plus is our residual volume, and our vital capacity is the dark blue, the orange or the yellow, and the purple. That is our VC. But I just said the purple plus, which is our IRV, our yellow, our orange, which is our TV, plus the ERV plus the RV. It's the same thing, I just broke it down a little bit further as to what the VC is. Okay, so don't get confused. Look at that chart if you get confused. Okay, so now we are looking at the various disorders. We have restrictive disorders. Those are those that reduce the pulmonary compliance. Now that's going to limit the amount to which the airs can inhale. It's going to limit how much air you can actually bring in, because the lungs are not expanding as much as they're supposed to expand, and they can't fill up with air enough. So there's going to be stiffness in the lungs and any disease that produces pulmonary fibrosis. So it makes changes in our lung values. So we saw our lung values. So what's going to happen with our lung values? You're going to have a decrease in our VC, which is what? Our vital capacity. A decrease in our residual volume. You're going to have a decrease in our FRC, our TV, our VT, our TLC, and our and our FVC. All these volumes are going to change. They're going to decrease. What causes it? You have an interstitial lung disease. You have obesity, sarcoidosis, neuromuscular disease such as muscular dystrophy, amyotrophic lateral sclerosis. These various things that can cause a decrease in the values, which are restrictive disorders. Oh, asbestos, lung fibrosis, black lung disease, TB, pneumonia, and pulmonary edema. Now we look at the obstructive disorders. Those are going to interfere with airflow by narrowing or blocking. So you notice the difference between restrictive and obstructive. Make sure you know the difference between the two. You're going to see that again. With obstructive, basically, the airflow is being blocked. One's dealing with a blockage, one's dealing with something not, it's compliance, not expanding. So basically these are expanding, but there's something blocking it from the air getting to the area. So it makes it harder to inhale or exhale, or a given amount of air, especially during activity or exertion. So when you have a decrease in breath rate, it causes a decrease in time to breathe all the air out before the next inhalation. So that's people with asthma. So what kind of changes do you think you have in the lung values? You'll have a decrease in your VC, your IRV, your ERV, and you have an increase in your RV, your residual volume, because you can't get all the air. So what you have a leftover of air left back in that residual volume, which you want to increase it. You have your FRC, increase in your RV divided by your TLC. Some common obstructive diseases. What do we have? Asthma, chronic bronchitis, COPD, cystic fibrosis, emphysema, and emphysema. Alright, so we look at the spirometry some more. Yes, there's a lot of information. I know, I'm so sorry. When we look at this, we have looking at the percentages. Okay, now the percent of vital capacity, or VC, that can be exhaled in a given time interval. We have healthy adults. They'll read approximately 75% to 85% in 1 second. Now at home, patients can use a handheld meter to measure their peak flow, which is the maximum speed of expiration. Let's see. Yep. So these are just definitions that we have here. Okay. So peak flow is the maximum speed of expiration. That's dealing with blowing into a handheld meter to help get that recording. Then we have the amount of air inhaled per minute is called a minute respiratory volume. So they'll have you breathe in and out for 1 minute as fast as you can. In and out. Extremely in and out. Deep breaths. And you got to exhale everything out as quickly as possible for 1 minute. And that's considered your maximum respiratory volume. So basically, how are you going to handle running a race, running on a treadmill, running from a dog, climbing upstairs? Basically, you're going to need that maximum volume. And that volume at rest is supposed to be 6,000 milliliters per minute. Okay. Then we have our maximum voluntary ventilation, or MVV. Oh, sorry, I'm mixing them up. Our MRV, our minute respiration volume. This is basically breathing normally for 1 minute. Let me not mix that up. MRV, breathing normally for 1 minute. They're going to measure the amount of air coming in and out for 1 minute. Now your maximum voluntary ventilation, that is you. That's what's going to be utilized during heavy exercise, running from a dog, if running from something, and that's when you're going to breathe in and out as hard and as fast as you can for 1 minute. So that's the one I was trying to demonstrate. I mean, don't mind my demonstrations, but that's for exactly 1 minute. And some people do get lightheaded. That's another sign of some type of disorder. But it is very important that the person do this particular exercise so we see how their lungs will work under strenuous exercise or strenuous work. Okay, and it may be as high as 125 to 170 liters per minute. Now some more definitions. Relaxed, quiet breathing, and is characterized by a tidal volume 500 milliliters and a respiration rate of 12 to 15 beats per minute. What is that called? It's called apnea. apnea. Relax, quiet breathing. Temporary cessation of breathing, what's that called? Apnea. Labored, gasping breathing, shortness of breath. I've mentioned that word before. Hopefully you remember. It's called dyspnea. Increased rate and depth of breathing in response to exercise, pain, or other conditions. What is that called? Hyperapnea. And then increased pulmonary ventilation in excess demand. Can't see that there. Is called hyperventilation. Some more definitions. Reduced pulmonary ventilation is called ventilation. Make sure you know these terms. You will see these again. I guarantee you will see it. Deep, rapid breathing, often induced by acidosis, cosmal respiration. Dyspnea, which you already know is shortness of breath, that occurs when a person is lying down. Orthopnea. Permanent cessation of breathing. Respiratory arrest. Then we have accelerated respiration is tachypnea. Yes, there's a lot of information. I know. But if you have any questions, please feel free to write it in the comment section. Okay? And we will proceed to lecture 3 of 3 for the respiratory system.